Hello? Ma'am, I'm not able to see the presentation actually. So, sorry for the delay. So again, there is some technical issue. So now we'll go from the beginning. So today we are going to discuss about the management, surgical management of diabetic foot ulcer. First, actually, we have to know why in patients with diabetes, why we are getting the ulcer and the progression of the disease. So how it is getting progress from small ischemia, shock, multiple organ failure, and the patient's death. So this is not a simple thing so that we can avoid. It's a small ulcer. It's not like that. It's not a small ulcer. The small ulcer will become big problem. The patient may lose or the patient may lose his life. So for every small ulcer in the patient, particularly in patients of diabetes, so we have to take care of it very well. So now this diabetes, as I already told, it's not just a small ulcer, it's a foot at risk. So we have to know the risk factors for the patients with diabetes for an ulcer. We will go through later to the frank gangrene, which leads to amputation later. So among the total number of diabetes in the world, so 50% of them, so they are getting this diabetic foot ulcer, and 50% of them are recovering the amputation. That is a removal of the limb after the limb becomes gangrene and the sepsis because of infection. So we have to remove the limb, otherwise the patient will lose his life because of sepsis and multiple organ failure. So it accounts for the 24% of mortality in patients with diabetes. So you all know that diabetes not only affects the foot, it affects kidneys, it affects eyes. The patient may lose his vision if you don't treat at right time. So the patient, and also it leads to atherosclerosis. Atherosclerosis means the blocking of the vessels. That if it occurs in the heart, that is myocardial vessels, they may go for immediate myocardial infarction, we say the heart attack, and then the patient will die immediately. So diabetes is not just controlling the blood sugar. There are lots of complications of them. So now today we are going to discuss this ulcer. So how the patients living with diabetes, how they are going for ulcer, and then how to manage it, how to prevent it. So first we have to know the reason behind that. So why this diabetes patients are getting ulcers, how it is happening. So basically you have to know the will cause peripheral neuropathy. Neuropathy in this sense, a patient will lose his sensation. So the patient doesn't know that they are getting injured. Like while walking on the road or some sharp things, if it injures his leg, so they don't feel the pain. So not like a normal people, they don't feel the pain. So they will ignore the wound. So they don't know that they got injured. So what we will do, we will just put an antiseptic, we will clean it, and then we will put a dressing and all. Those people doesn't have any symptoms. They never feel pain. So ultimately affected, and the infection will grow rapidly. It will proliferate. The bacteria will proliferate so easily. Then they will go for sepsis. Then ultimately septic shock, and the patient will die. So other reason is peripheral vascular disease. As I already told, patients with diabetes, because of increasing blood sugar, they will go for the blocking of the blood vessels, as I told, not only in the heart, all over the body. So if it occurs in the limbs, what will happen? The extremities won't get the blood supply, gangrene. So, and then the gangrene will move proximally towards the core of the body, then ultimately we will lose the limb. So this neuroischemic means both, and then peripheral vascular. So already the patient's limb will be ischemic because of the loss of blood supply, and then the loss of sensation will be there. So the both will join together, and then that will be more, that will cause more problem. So another thing is we have to know that diabetes patients are immunosuppressive. They will be in immunosuppressive state. So whatever the infection they are getting, so it not like a normal, healthy people's immunity. Their immunity will be very less. So the neutrophils and leukocytes, they never, other leukocytes, they never come to the action to destroy the bacteria. Ultimately, the bacteria will proliferate, and then it will cause damage. So they are more prone for infection. These diabetes patients, because of high level of glucose level, they become immunosuppressive and they are more prone for infection. So next slide, please. Yeah. As I already told, peripheral neuropathy. Neuropathy, we all know that sensation, and then motor function, and then autonomy. These three things will come. So as I already told, it's sensory neuropathy. The minor injuries will be there. They won't feel pain. So obviously it will lead to infection and it will progress. So motor neuropathy means here not only the sensation but also the function of the muscles, agonist and antagonist, the extensors or flexors, they don't function properly. Walking, their movements won't be good. They will the way as people are going, because they are not having that sensation. The motor system of them is also not functioning properly. So ultimately they are more prone for trauma. They will fall down a small uneven surface. They cannot walk because the coordination of muscles won't be there properly. So next slide. Next slide. Yeah, as I already told here again, macro and micro. Macro means big vessels. Big vessels in the sense here, aorta, external iliac, femoral vessel, these are the big vessels. Micro means the small vessels which are supplying the extremities, the toes. So they both will occur in different way. Yeah. Next slide, please. Yeah. So now, who are all at the risk for diabetes? So you also have to know that the patients living with diabetes, who are all at risk. So whom we have to take care of. So if the diabetes more than 10 years, if somebody is taking medicines for diabetes or without taking medicines also, if it is for more than 10 years, they are at increased risk. So, and the sugar control should be like in proper way, that they have their FBS, PBS, they have to check often, then they have to maintain the glucose level in a proper way. So, and obviously I told they will be having decreased immunity, and the patients with previous amputation and then previous healed ulceration. If there is any ulcer which is already present, which is healed, so in the healed portion, they are more prone for the new ulcer formation. So this, according to the Wagner's grading system, they all will come under the grade 0. For this, we have to prevention is, we need to prevent the ulcer. So there is no need of any treatment. So we have to be careful in these conditions. Then we can prevent the ulcer in the early way. So, next one. So this actually we will discuss later also. In this classification, we have to know the grading of the ulcer. So so obviously in every ward, every hospital, the new patients are admitting. So we are just checking their sugar levels. First we will do the RBS at the day of admission. The next we will do FBS and PBS to know the actual level of blood glucose. And then HbA1c will do to know the blood level for the last 3 months. So every patient we are checking these levels, and we have to examine the food. In this case, the patient will come with these complaints. At grade 0, as I already told, in this picture, the patient is having the callosity here. So this is, we used to call it as callosity because the patient giving pressure on this area while walking. So what will happen? The skin, this area, it's more prone for ulcers. So the patient is not having no ulcer. As I already told, this come under grade 0. So grade 1 here, superficial. The ulcer here, you are able to see the ulcer here, which is superficial. It's not going deep. Only skin and subcutaneous tissues are getting involved. So in this grade 2, we can see that it is penetrating. It is little deeper. You are seeing, it's deeper. Just it's not infected, but skin, subcutaneous tissue, and then what will be there? Muscles will be there, tendons will be there. These things will get affected, but there is no infection. So grade 3 here, you can see there is a slough. Lots of slough is there. The yellow color tissue, what we used to say here, these are all dead tissues. They already died. It's got necrosis. It's not living one. So this will come under grade 3. And grade 4 is local gangrene. So if black discoloration is there, here the grade 2 on base of the grade 2 you are seeing the discoloration. This is gangrene. If there is a gangrene, obviously we have to amputate it. But in this picture, we can do the wound debridement and then we can wait for before amputation. So this is grade 5. Extensive gangrene is there. The blackish discoloration is going, it's going proximally up to the ankle. So we will discuss it, slowly in the coming slides. So next slide, please. So as I already told, this again I put it over in the fonts. That grade 1 is superficial, grade 2 is deep ulcers, grade 3 is deep ulcer. Osteomyelitis is infection of the bone. So slowly the ulcer will erode the tissues and it form abscess or it bone will be there. So the bones will get infected. Called osteomyelitis. So grade 4 is 4 foot. 4 foot means the distal foot. So grade 5 is hind foot gangrene. So next slide please. So how the patient will come to hospital? So it can happen in two ways. That is elective and emergency. So emergency, as I already told, if the ulcers are not treated promptly, so what will happen? The patient will have lots of bacteria will grow in the wound. Then the bacteria will go to the bloodstream. They will release lots of interleukin cytokines. It will cause sepsis, and then the patient will go for shock. So I think you people know what is sepsis and shock. The thing is, the bacteria in the bloodstream will release lots of cytokines. It's called systemic inflammatory response syndrome, we will say in the beginning. So later it will go for multiple organ dysfunction syndrome. Mainly the kidneys and liver will get failure. Then finally the patient will die. So we have to treat in emergency. We have to do wound debridement. We have to do abscess drainage. So for that, you people have to assist. So you have to know why it is happening, how it is happening. So this elective means obviously small ulcers. As I told, grade 0, 1, 2, 3, these things will come under elective thing. That patient, we have to ask the detailed history regarding other symptoms also. That diabetes will also affect kidneys, will also affect eyes and other organs like myocardial ischemia, in fact, history of heart attack. We have to ask all this detailed history and the risk factors for that. Next presentation. So this examination part, basically just slowly we have to do that. But the absence of hair, why there is an absence of hair? Because ischemia is there, so there is no blood supply to the foot, so it causes all the hair to get fall off. The callosities, which I already told, the pressure points. In the pressure points, the patient gives the pressure on walking. The pressure, all the pressure points will get, the skin will get thickened, and those areas are more prone for ulcers. So discoloration, I said gangrene, like blackish discoloration will be there, you have to see. And the ulcers characteristics, you have to see the characteristic of the ulcer, because ulcers are not only in diabetes. There is lots of causes for ulcers. That is arterial ulcer, venous ulcer, lots of types are there. So arterial ulcer means only blood supply is not there. So only the arteries are getting blocked, it got inflamed, blood supply is not there to the foot, it will get ulcer and gangrene. So venous means varicose veins is the one condition where the venous drainage is not properly. Venous drainage of the lower limb is not properly happening to the heart. So venous blood will get pulled down and then it will cause an ulcer. So there are basic types of ulcers you have to know: arterial, venous, and diabetes. So obviously, if a patient comes to any hospital with diabetes, known case of diabetes and ulcer, you can think of it might be diabetic ulcer, and we have to grade it, as I already told, that grading, Wagner's grading. So on peripheral pulses, not like dorsalis pedis artery, anterior tibialis artery, posterior tibial artery, every pulsation we have to palpate, because we have to differentiate that this ulcer is because of diabetes or it's because of arterial disease. So for that we have to palpate. If all the peripheral pulses are palpable with an infected ulcer over the foot, then it is diabetic ulcer, obviously. So there is no doubt in that. So next slide, please. Yeah. So what are the investigations we'll do? There is a spelling mistake here. We have to. Yeah. So obviously, every patient who are getting admitted, we are doing blood sugar levels, HbA1c to know the 3 monthly values. And then this one is very important here, the wound swab or culture sensitivity, because the patient with infected ulcer, before starting antibiotics, we should not start immediately. We have to take a swab. We have to take the pus from the ulcer.